there seems to be very broad agreement that the use of low molecular weight heparin thromboprophylaxis for hospitalized COVID-19 patients is appropriate, but there are a number of groups that are advocating for intermediate or even full dose therapeutic anticoagulation. Is there a role at this time for intermediate dose or therapeutic anticoagulation in selected patients? And from all these questions, I pulled out an example. A critically ill patient whose D-dimer had been stable around 2,000 and suddenly increased to 10,000 the following day, too unstable to go to CT, leg Dopplers negative, and no easy access to Factor 10 monitoring. So what about that? Eric, you want to take that one on?
Sure. So thank you for those excellent questions, and they're certainly on everyone's minds. It's quite controversial right now about what to do. As I mentioned in my presentation, unfortunately, at this time, it's difficult to make definitive recommendations on intensified prophylaxis regimens in the absence of data. So I think the general approach to a patient who's in the ICU or on the ward would still be until we have more prospective data, weight-based standard low molecular weight heparin prophylaxis. I do acknowledge that the clock study that I just presented this morning does suggest that there are higher VTE rates in patients who are critically ill, but we do have to recognize that this is one observational study, and there are methodologic limitations to any study, any single center study, particularly when the outcomes, for example, included a lot of subsegmental pulmonary emboli and the lack of a comparator group. My general statement would be that in situations where there's a perception of higher risk, whether it be mechanical ventilation, other personal VTE risk factors like cancer, increased body mass index, hormonal therapy, it's never wrong to consult with your colleagues, a hematologist or thrombosis specialist if you have access to someone, and take into account the patient's bleeding risk, obviously. I will also say that there will be more data coming out in the coming weeks to months, and there are already several clinical trials that I have heard about comparing different prophylaxis regimens in different groups of patients. So that's the one question. The second question was around what to do in a patient who is having serial D-dimers monitored in an acute care setting. I think it is challenging to know what to do with this because while the D-dimer, while that ZOE study that Dr. Lang had shown a progressive rise in D-dimer concentrations in patients who were eventually heading towards death, it's hard to know, again, whether that's part of simply the systemic inflammatory response or a reflection of underlying or ongoing thrombosis. So I think in general, in these situations where D-dimer is surprisingly elevated, we again have to come back to assessing what the clinical pretest probability of this patient is. Was this an unexpected deterioration? Are there alternative explanations for why the D-dimer is elevated? Have we done the best that we can to get objective testing done to confirm VTE? And then the empiric decision about therapeutic anticoagulation in this situation needs to take into account, obviously, the pros and cons and the bleeding risk factors for your particular patient.
Very thorough response. Thank you very much, Eric. Sudeep or Deepa, do you have anything to add to that, particularly in that patient who's in the ICU and going right down the tubes with respiratory failure, perhaps, or other complications?
So you know, I think as Eric had alluded to on the slides, you know, I think for somebody with COVID-19 and respiratory symptoms, PE is a concern. I think in every case, every effort should be made to try and nail down the diagnosis of a thrombosis before anticoagulation at full doses is used. This could be compression ultrasounds, This could be perfusion-only scan by nuclear medicine, and it could be the use of echo or POCUS, although those may not rule out the disease. If they happen to show a thrombus in transit, you have your diagnosis and have a rationale to start full-dose anticoagulation. Now, in the case where somebody is decompensating and you don't have the diagnosis and they have a high D-dimer and they really look clinically like they're having a really bad PE, I think it's a case-by-case basis as to whether to empirically use anticoagulation, full dose. But I think my take-home message, or my message, is to do whatever you can to really try and get that diagnosis nailed down. And the other cases will just have to be a risk versus benefit analysis.
All right, thank you. Still on the topic of D-dimer, we have somebody asking about the value of D-dimer as just a prognostic indicator at the time of admission, or is it recommended to continue to do follow up with serial D-dimers in hospitalized or ICU patients? Eric, I'll point it to you.
Again, I think this is a controversial area. Certainly, as we've discussed, the D-dimer has prognostic significance, but we don't know yet what to do with that information. I think at this early point, any information is helpful. So whether the D-dimer and other inflammatory markers like C-reactive protein, ferritin, etc., reflect underlying inflammatory state, I still think they provide some prognostic information. And so I think we should balance minimizing the blood work that's necessary, but also trying to gain as much information as we can. So I am a believer in serial D-dimer collection, while minimizing the amount of blood draws and exposure to patients if possible.
All right, thank you. Any other comments on that? Okay. What about thromboprophylaxis regimens for patients who are hospitalized with COVID-19 but not in the ICU? Different regimen for patients who are on the ward? Deepa?
At this point of time, I think, with the, until we test it in a clinical trial, I think, we should stick with what we know the best, and that would be the safe alternative, just to give them prophylaxis. And each institution has its own protocol around thromboprophylaxis, but certainly that needs to be followed, and weight-based recommendations at this time until we know better.
Fair enough. What about anticoagulation regimens being used for patients, the sickest of the sick, on ECMO? Is there any difference in how those patients might be managed? I don't know who wants to take that one on. Any of you? Jim, Deepa, Eric, Sudeep? ECMO, you got any experience?
It's a controversial area, Alan. As Eric already alluded, I think at this point of time, there's so many unknowns in that way. But these are already sick patients, and if they're on ECMO, they're quite severely ill. In that cases, I would say, and again, this should be tested. I'm not saying that, we definitely need more studies to help us understand, is there a role for an escalated doses of thromboprophylaxis in these patients, but should be done in a clinical trial basis, but otherwise continue with the prophylactic regimen that we already have in place.
All right. We have a question here asking about anyone who is considering ROTEM or other tests of looking at thromboelastography to assess hypercoagulability in COVID-19 patients. Questions aren't easy, eh?
No.
Who wants to take that one?
I can tackle it. So at this point, that would be investigational at this point. I think ROTEM and thromboelastography have been used for very specific indications, and so I think if we had that information, it would be hard to know what to do with it. There are some prophylaxis algorithms out there that have actually looked at combining D-dimer concentrations and TAG or ROTEM results, but again, these are not tested with any prospective data. The other thing we need to keep in mind with any of these really investigational protocols is, it's increased blood draws. ROTEM, you're taking a sample, exposing more laboratory personnel to another blood sample, and so I think we need to be judicious about what we know and perhaps what's exploratory at this point. So I wouldn't do that routinely in our practice.
This isn't exactly a question, but I do want to just bring out to our audience a comment from our colleague Tammy Bungard, who addresses the issue about point-of-care INR monitoring and the cost. Tammy points out that the device, the CoagCheck INR range device, is available to patients for about $400, and the cost of test strips is $50 for a box of 6, $208 for a box of 24. So probably not all that prohibitive if a patient is being monitored monthly. 6 strips is going to last 6 months for $50. Not really so bad. I have a very specific question from an ICU pharmacist who has observed a number of the patients in their ICU who are critically ill with COVID requiring dialysis, and they've been using SLED, sustained low efficiency daily dialysis, and they've been having major issues with clotting within the dialysis circuit despite the use of heparin, and they're seeking guidance on how best to manage that. Jim, can I put you on the spot with that one?
The issue of circuit viability in dialysis patients is very problematic, and it would be very premature and speculative for me or anybody else to say that there's this COVID-specific interaction. A lot of these patients, the issue is not coagulation, it's more the circuit and the more rheologic or vascular related issues. So I don't really have a good answer to that. I don't think there is anything in the literature that speaks to that. And, in a lot of these patients, we're dealing it on a case-by-case basis, whether with low doses of lytic therapy or other mechanical methods. But I don't think that the management should differ in this instance particularly.
Thanks, Jim. There's a lot of controversial issues out there. One of them is the use of hydroxychloroquine in these patients. And we have somebody asking whether the platelet threshold for decreasing the heparin dose should be any different in patients who are receiving or not receiving hydroxychloroquine for the management of their illness. Sudeep?
So yeah, that's a really good question that I actually hadn't thought about before, but not to my knowledge, and please correct me if anybody has any further information about this, but I would not say that platelet thresholds should be changed for patients on hydroxychloroquine. I'm not aware of any studies that suggest that.
All right, thank you. We have a question from what sounds like a rehab physician who's talking about patients who have been diagnosed with COVID-19 while in rehab or complex continuing hospital care with mild symptoms who would otherwise not be hospitalized and managed in the community. So these hospitalized patients, should they be receiving thromboprophylaxis? I'll put that one to you, Eric. So patients with mild illness but hospitalized.
So that's a great question. I think a lot of times in the rehab setting, they are kind of in this intermediate zone between ambulatory and hospitalized, and not just with COVID, but in general, there's not great data for these groups of patients. I think that is a case-by-case decision, taking into account bleeding risk and patient preference. But it would be, but I do not think it would be inadvisable to offer that, as long as there is a decision made with the patient about that. And then in terms of the agent, I would, if the decision was made to proceed with pharmacological prophylaxis, I would use low microwave heparin. Not sure if anyone else has thoughts on that.
I would agree. It's a case-by-case basis, to evaluate that need for thromboprophylaxis in those patients.
Recognizing the need to minimize blood draws and worsen anemia in hospitalized or ICU patients, we have a question regarding the role of looking at complement levels or ADAM-TS13 or von Willebrand levels in sick COVID patients in view of the suggestion of microangiopathic thrombosis.
I think it is an area that is of interest and is going to require more study. I do believe that I can't quote the evidence specifically, but in a recent series, the ADAM-TS13 level was not extremely low like you would expect in a thrombotic microangiopathy. So it may be a different mechanism, but I think more study is needed in this area.
All right. Anybody want to comment on microangiopathic disease in COVID-19? We're seeing strokes, we're seeing elevated troponin levels, we're seeing acute coronary syndromes. Does anybody have any insight into that one?
Hi, Alan. It's Deb Siegel. Can you hear me?
Yeah.
As far as I understand, this is an evolving area. I'm not aware that there is evidence of fragmentation hemolysis that you would expect in order to establish a diagnosis of microangiopathic hemolytic anemia, something like, TTP, which is what people are thinking. And there has really not been evidence of low ADAM-TS13 levels, as far as I understand. Now, people are looking into this more and we'll get more information, but right now it doesn't look like this is a thrombotic microangiopathy or MAHA, at least according to the strict criteria.
But thanks.
Other people are free to disagree, but that's my understanding.
Okay, thanks for coming on, Deborah. So I'll put you on the spot now. Okay, so there's been a lot of obvious need for ongoing clinical research in this area of thrombosis and COVID-19. And somebody has asked the question, will there be an RCT comparing therapeutic low molecular weight heparin against prophylactic dosing? But I'll expand that question and see, Deborah, do you have any insights that you can tell us about what ongoing studies are happening now and what we can expect to come out in the next months to help titrate?
Sure. So as you can imagine, I've been having my ear to the ground, trying to read on Twitter. We have an online consultative hematology community. People are welcome to join if they reach out to me. That's totally, it would be very good to have more people join. So the issue of clinical trials is obviously one that's top of mind for everybody, and people are around the world actively trying to develop protocols rapidly. I'm not aware of anything right at this time that's up and running in Canada. I know that people in the States are looking at single center studies sort of with institutional protocols for dosing, but no comparative studies up and running right now. I am aware of a few that are in the works, so maybe what we can do as part of Thrombosis Canada is to post information about clinical trials once they're up and running to help communicate that to people so they can see if there's anything that they can participate in. But certainly the issue of prophylactic versus higher prophylactic doses or prophylactic versus therapeutic doses is something that people are wondering. I think one of the biggest concerns is that if we all decide that we're going to change our dosing strategy for prophylaxis without evidence, it will impair our ability to gather evidence. So it's very important for us to make sure that we're making decisions that are in keeping with best evidence available right now, knowing that this is a changing landscape.
Thanks, Deb.
Yeah, no problem.
Okay, so there's been a lot of the reports that we're seeing are reporting prognostic changes in prothrombin time, but typically we are seeing INR, not prothrombin time. So is there any difference if we're looking at the number of seconds of a prothrombin time against an INR level? Eric?
As you know, the INR is a calculation based on the prothrombin time using a coefficient as a correction factor. It's hard for me to comment on that specifically because the publications that have looked at prognostication have used prothrombin time specifically and not the INR specifically. Now, if your lab is not set up to report a prothrombin time in seconds, I'm not sure that there's enough value in the prognostic information from that one particular parameter to change how things are done. I think there are other markers that we've talked about today that are also likely to provide similar information. But I do think that if you typically run an INR in your hospital and you're noticing that the INR is also prolonged, and along with the other factors that might be a signal that that this patient is progressing. But it's hard to know. That's not how the studies were done.
Alan, can I make a brief comment on that? Can you hear me?
Yes.
Hi. For people who don't currently report the prothrombin time as part of their normal report, you can actually call the lab and they can provide you the raw PT for that patient as a verbal because it is generated. A lot of institutions have moved to reporting the raw PT because of DOAC considerations, when the DOACs came on board and we were starting to look at assessment of bleeding. So a lot of institutions moved to reporting both, but in institutions that are not reporting it, they can call the lab and get a raw PT report if they're interested in a case-by-case basis for a particularly sick COVID ICU patient, by example.
Yeah, there was a suggestion in the ISTH seminar yesterday that INR may miss some cases of alteration in prothrombin time. So, one of the most I thought controversial recommendations in the algorithm from ISTH that was presented by Eric today was maintaining fibrinogen levels above 200 in non-bleeding patients. We have a participant asking about the rationale for that and if that is a useful recommendation. Jim, can I point that one at you, maintaining fibrinogen over 200?
Sure. Well, I mean, in general, I don't think there's really sufficient evidence, whether in COVID positive patients or even in non-COVID patients, that we need to maintain a fibrinogen level in the absence of clinically overt bleeding. So I think the short answer is no, but I think it should be looked at in the broader context of other clinical as well as laboratory parameters. And, we need to conserve blood resources in general, and this is not something that I would use, for example, to transfuse cryoprecipitate or fibrinogen concentrate. It should be driven by whether there's clinical evidence for bleeding.
Yeah, right. This was actually, specifically in non-bleeding patients, which I thought made it particularly controversial. We have some sort of interesting questions here. Somebody asks that there are features of COVID-19 that seem to be similar to hemophagocytic syndrome. What do you think about treating patients with severe or critical illness? Because there's going to be no shortage of those with approaches like plasmapheresis or etoposide.
Well, I can take that. HLH is a very rare but very serious condition. Cytokine storm is another term for it. And there are some features of COVID-19 that may overlap with HLH. And as I mentioned earlier, it's referred to as the cytokine release syndrome. Even with HLH treatments, as I think we all know, are based on very limited evidence. And if we're looking at things like etoposide, I think it needs to be done on a case-by-case basis, very selectively. Also, as I mentioned earlier, there's a wide array of treatments being currently intensely investigated that would be I think where we want to look towards, rather than just putting out there presumptions. I think we want to try to keep this as fact-based and evidence-based as we can. And I think we're going to have these answers sooner than we think. Trials are being approved at lightning speed. So we're going to have a lot more answers about treatments within the next, I think, 2 to 3 months, if not sooner.
Do you know of any institutions that have tried these things in patients who are going to fail otherwise?
Well, anecdotally, no. And I mean, the other thing I'd like to point out just in general about today's presentation is that although we're relying a lot on evidence, we also are trying to interact with colleagues around the world in China and Italy, Europe and New York, other hotspots. So we're trying to summarize that collective clinical experience in concert with the literature to provide some insights for clinicians here in Canada.
Thanks very much, Jim. I would like to take this opportunity to thank all of the participants. I would also like to thank all of the speakers. We will be repeating this seminar again in a couple of weeks. So Thursday, April 23rd, 2 p.m. Eastern Time, we will be doing this session again. Feel free to register again. I suspect 2 weeks from now, we are going to see some new information that we will hopefully be able to present to you at that time. Please advise any of your colleagues that may be interested in participating to join in as well. So thank you all once again, speakers, participants, everyone. And I also want to take this opportunity to thank our sponsors, Bayer Canada, BMS, Pfizer Alliance, Leo Pharma, Novartis Pharmaceuticals, Pfizer Canada, and Servier Canada for their unrestricted grant, truly unrestricted grant of this program. So thank you very much and good afternoon.